So the Waltham Forest, East London and City Pioneer Project is one of the 14 national sites for integration Pioneer programme. It began in 2012 with a big piece of work that was done around the case for change. And I think that's where the benefits of linking up data really began, because the case for change was built on a one-off linkage of health and social care data that was done with as much data as we could hoover up in order to build the case for change. I think we've built on that since the case for change was completed in order to try and make sure that wherever possible we are linking back the work we do around outcomes, the work we do around targeting patients and trying to find the right patients to put through our service model, with as much data as we possibly can. So at the time when the case for change was done, we had good hospital data, almost 100% general practice data. Now I think we're looking to build in mental health data sets, community health services data sets, and at the time we had some local authority data, but we're looking to do that much more systematically. There are two ways that we think about linking data across the WELC Pioneer programme. Clearly, data linkage for clinical purposes, so this is live clinical data, is a massive enabler to services working together. And that's really being worked on in each of the boroughs, looking at how they string together a patient's record for as an integrated digital record, really, which is about data that people would use for clinical decision making. So that's one piece. I think that what that enables is clinicians on the ground to really talk to each other about individual patients. I suppose the development of that will be trying to work towards patients having access to their own records as well, and putting them much more in the driving seat of their care. That's one half of what we're doing. The other half is really the business intelligence piece and the big data piece and the bit we're all talking about today. So that enables us to, first and foremost, identify the right patients to target our integrated care interventions. But then we're also using that to do the measurements. So to look at, track across those cohorts of patients what's changing in the system. And we're evolving the way that we do that as we go along. And I think that the last piece connected to the business intelligence is really looking at how we finance the system. So we're looking towards capitated budgets for groups of patients, payment on outcomes, so to build the right incentives and the right flexibilities into the system for our providers to work collaboratively. The biggest challenge really is around people understanding how data might be used once it's been linked up, because it's really hard to show people what the potential is without having a linked up data set. So you have to win people over to start with. And I think in particular the GPs who have probably the richest source of data and are also have been asked over a number of years to do the most around protecting that data. So things like the IG toolkit, all kinds of other pieces of work that they've had to do to understand Caldecott. So in a way, their natural reaction is not to share data because they've been told not to share data. So hearts and minds, easily the biggest challenge. Then there's a technical challenge. And that's about, building a warehouse, understanding how to link data. And then, of course, our biggest challenge came when the Health and Social Care Act came in 2013 and the goalposts change. So we had to then rebuild and understand how to change our system to cope with a change in the law.